Welcome to the Heart of Prevention, helping clinicians stay up to date on preventive cardiology. This show features leading experts discussing real-world strategies to prevent heart disease, from lifestyle changes like diet and exercise to medical treatments, including new therapies. Whether you're a medical student, resident, or practicing clinician, this podcast challenges, informs, and enhances your approach to cardiovascular disease prevention. The Heart of Prevention, keeping hearts healthy one episode at a time. I'm Dr. Michael Shapiro, President of the American Society for Preventive Cardiology, and now here's your host, Dr. Khurram Nasir.
Dr. Blaha, Dr. Nasir, welcome to the Heart of Prevention.
Well, thank you so much for having. It's good to see Mike's here. We've been working together on this area almost for 18 years. So, Mike, good to see you too.
Good to see you, Khurram. Thanks for having us on.
So we're going to be talking about a really fun topic today, the calcium score, and who better than two experts in the field. And before I start in with our questions, I'm just going to take a little bit of time to introduce them. So Dr. Michael Blaha is a professor of cardiology and epidemiology and the director of clinical research for the Johns Hopkins Coronary Center for the Prevention of Cardiovascular Disease. He's also the director of the Cardiometabolic Clinic and program director for the Preventive Cardiology Fellowship. Dr. Khurram Nasir is Chief of Cardiovascular Disease Prevention and Wellness at Houston Methodist DeBakey Heart and Vascular Center. He's also the William A. Zogby Centennial Chair in Cardiovascular Health at Houston Methodist, the co-director of the Houston Methodist Rice University Digital Health Institute, also the program director for the Preventive Cardiology Fellowship at Houston Methodist, and our newly minted editor-in-chief for AJPC. And that's not even all-inclusive of his titles. So we're really excited to be talking about the calcium score today. And I always like to start by asking our guests, what was that moment in your training or early career when you realized that prevention, and maybe not intervention, was going to be your focus? And we'll start off with Dr. Nasir.
Wow, that's a big one. I would say that first aha moment was during my training at School of Public Health way back in 2001, when I heard Dr. Roger Blumenthal giving a lecture on prevention. And I think so that was the time when prevention wasn't a thing. And coming from a mindset of public health and originally trained in a low middle income country where it made a lot of sense, like, wouldn't it be better if we can have efforts upfront and prevent it from occurring from the first phase? So I think so that's really what got me started. And of course, the rest is history, where all of my prevention efforts, or I would say my interest, has happened working with the Ciccone Center, and Roger has played a major part in getting us in that direction.
I love that. Dr. Blaha?
Yeah, that's a great question. So I was always interested in cardiology, but the things that got me interested in cardiology weren't necessarily the things that some people get excited about, maybe the interventions for the acute MI or the critical care. I was always interested, as Khurram said, from the public health perspective. I was always interested in the most common disorders, the most common diseases. So coronary disease and the risk factors, hypertension, hypercholesterolemia are always the most important to me. It seemed like the most, durable interventions that we could do, or the most sustainable interventions for prevention. So that really started for me, I guess, also through my public health training. I did training in medical school, came to residency, worked with Roger Blumenthal, and really already identified at that time, even in residency, as interested in preventive cardiology. And once again, because I want to work on common diseases, make big population impacts, things that not only impact the patient in front of you, but the population at large. And I think Khurram and I shared that same vision, really, which is one of the reasons we got to be such good friends so early on.
Absolutely. I love that. And so breaking it down a little bit for our listeners who might not be familiar, can you explain what exactly a coronary artery calcium score is and what it tells us? And really, why does it add value beyond traditional risk factors? And I know this could be a whole episode in and of itself, but we'll start with Dr. Blaha.
Sure. Well, yeah, I can take a little history too of why this got me interested too. So, of course, you get interested in prevention, you get interested in things like risk prediction. And quickly you recognize the weaknesses in the current risk factor models, right? We all know this. They're largely driven by age, sex, or gender. Their modifiable risk factors really don't make as big of a difference as you might think in risk assessment. And you recognize that, as soon as you start practicing, that risk factor models just don't do it as far as individualized risk prediction. So I was early on in my residency already recognizing this. And then when I first was exposed to the calcium score, or first exposed to the idea that you could directly image the coronary arteries, I was like, well, this just makes perfect sense. What better way than just estimating, or as Khurram would like to say, guess and treat? Well, just directly imaging and treating accordingly based on how much disease an individual patient has. So the whole concept made sense to me. And then when I learned about the calcium score, it further made sense. Of course, the calcium score is a non-contrast cardiac gated CT scan, can be done on any modern multi-detector CT, can be done in a few minutes. All you need is electrodes on the chest to gate to the cardiac cycle. Only need a couple leads. And it's so rapid. And importantly, you do it the exact same way no matter where you are in the world. If you're in Houston or Pakistan or wherever, you do it the same way, as opposed to a CT angiogram, which is more operator dependent or technology dependent. You do this the same way. So the fact that it's done the same way everywhere you go, it's rapid, it's inexpensive, and also we score it, which we'll talk about, I'm sure later. We score it the exact same way no matter where you go. So it's highly reproducible. Immediately made sense from a screening or I should say at least a population risk stratification point of view. So it's once again, it's simplicity, which is actually why you know, some people want to replace it with other fancy technologies, but it's simplicity and it's just common sensibility, which is actually what got me so interested in it. It's just so simple, so easy, so cheap, and that's what makes it potentially applicable at scale.
So, Mike, I would say I love how you spoke and give a detailed insights on the applications broadly, even from a population health standpoint. I would say from my perspective, to add on, even as preventive cardiologists or general physicians, every time we meet a patient, especially in this space, one question that really defines the rest of our encounter: what's your risk? And that simple questions determines now how only we are going to act, what test are we going to order, what treatment we start, what future we plans. And clearly for decades, and even right now, it's been answered using models which Mike referred to, the risk models, numbers, estimates. I always like to call, they kind of mislead us, and they have been the foundation, but depending upon how you shake the same ingredients in a box, the prediction changes. Sometimes you're right, sometimes you're way off. And that's where I think, so if you go back a little bit in the history, Arthur Agatston introducing this concept almost 35 years back, you'll be surprised to know that at first, truly the first abstract that just submitted introducing this concept was rejected by AHA. But his final paper became one of the most cited concept in cardiovascular medicine, non-contrast CT, low radiation, widely available, I would say still underused. But what was once dismissed as fringe now guides millions. And because, as Mike pointed out, not only it allows to visualize atherosclerosis directly, it is the root cause of events. And it's no longer about risk prediction anymore. It's about disease detection. And while we still continue to put a lot of weight on numbers, what's your LDL, what's your lipoprotein A, even family history, the calcium test tells us who actually has the disease versus who might not. So I always like to tell my patients that LDL tells you what's floating. The calcium test may tell you what's sticking.
Love that. That's a great point. Now, we've talked a little bit about, it's simple, it's fast, it's cheap, it's reproducible, it's still underutilized. But do you find that there are specific populations, whether that's women, younger patients, those with diabetes perhaps, where calcium scoring would be particularly useful or maybe less useful? And we'll start with Dr. Nasir.
So, of course, mostly the use is where you have the highest uncertainty, and the highest uncertainty within the guidelines, and that's now well acknowledged, is when you don't have what I would call high risk diseases. For example, you don't have diabetes, you don't have severe hypercholesterolemia, you're somewhere in the intermediate borderline. And that's where now at least everyone seems to understand that almost, if 1.5 or 1/3 you can reclassify to the low risk versus the high risk. So rather than chasing risk factors, it's better if you're about to prescribe preventive intervention for lifetime, spend 3 minutes scanning the arteries first. So in the old days, we used to chase risk factors. I would say now we listen, we do the calcium testing, and for the power of zero, I would say listen to the silence of a clean scan, because yes, the calcium score of zero ain't perfect, but it is still the best tiebreaker. Now, of course, the question is that there has been a lot of, rightly so, concern that what if you are traditionally at high risk? For example, if you have genetically confirmed FH, or you have genetically elevated lipoprotein A, or if you have diabetes. Now, a lot of work from multiple registries, often led by Mike and others, have shown that actually a significant proportion of them also have a calcium score of zero. And over the next 13 plus years, their risk is not that high. So it's again a call to rethink allocation of advanced therapies. Now, of course, there is a lot of uncertainty. What happens if you are younger? I would definitely say that now more and more data, and again, a lot coming from Mike's group, has shown that age is just a number. You can lower the bar. And the idea in the lower group is really trying to find early disease rather than ruling out disease. And most of the data has still suggested that the calcium score of zero still has the same favorable prognostic value. Now, as far as gender is concerned, I would say so far, none of the data has shown anything otherwise, that an absence of disease may be less, have a favorable prognosis in women than men. Although some data might suggest that for the same amount of plaque burden, if you have a calcium score of 5 or 10 or 15 or 100, it may be associated with slightly higher risk of a cardiovascular event. So in essence, I would say the good thing about the calcium testing is that it just does not discriminate you based on your age, gender, or race. If you don't have the disease, overall your risk is going to be low in the short, intermediate, or even long term. And by the way, it's not a test that you do once and forget it. And hence, if your risk is higher, estimated risk is higher at baseline, if your calcium score of zero and you're not pursuing intensive intervention, then you repeat it 3 to 5 years timeline based on the risk. I don't know, Mike, what's your thoughts on this?
Yeah, I completely agree. You hit on some of those big groups. Yeah, Y- exactly. Where the risk is uncertain, where the treatment is uncertain, is where the biggest value of the test is. Is it going to change my treatment, to change my risk assessment? Is it going to change my treatment? And as Khurram likes to say, not just initiation, but intensification. Not just do I start a treatment, but how intense should that treatment be? What should my risk factor goal be? So it's really everything about prevention that's dictated by the calcium score. Not that simple, just that simple discussion of do I start a statin or not, which is where we started 20 years ago. So other groups would be the groups where we chronically have uncertainty about risk, family history, of course, maybe younger patients who maybe have elevated lipoprotein A, as you've heard, family history. Other these risk enhancing factors, sometimes erectile dysfunction in men, some of these risk factors that are unique to women or South Asians. Anytime you have uncertainty about the risk is where the calcium score has such great value. So, and of course, everyone who's out there practicing recognizes that you see these patients every day. These aren't uncommon uncertainties. We have uncertainty about risk every day, and patients ask about their risk, as Khurram said, as the first question in prevention every day. So, really, I think what we're learning is the calcium score is broadly applicable, as Khurram said, to anyone who's really not definitively high risk, and even that is uncertain sometimes. But everyone who falls in the middle or in the low risk group even has some uncertainty, the calcium score has value. So really that's pointing more towards, as Khurram said, maybe even on the earlier age spectrum than we used to use the test. But really, of course, we're talking a lot about therapy. The calcium score has value even in, which maybe we'll talk about later, even in minimally symptomatic patients, in guiding reduced to testing in patients who have, pain syndromes and things like that. So it's even beyond just prevention. But really, I think that's the number one application. So um, uh, some of us have some uncertainty about this term risk enhancing factor, but at least we can all agree that those are patients who we don't know what to do with. The risk is uncertain.
Yeah, I love the comments that just some tidbits, so many great things in this discussion, but recognizing that the calcium score doesn't discriminate across different groups of people is something great to think about. Really leads back to that discussion about it's standardized, it's read the same way. And so we can really use it in those areas where we're kind of unsure. And I loved your comment about not just initiation, but intensifying. It's not as simple as let's just start the medication, but really like, how aggressive should we be? Because we're looking at something in front of us and that the power to show our patients exactly what's going on the inside is just really strong when we're having those shared decision making discussions with patients, especially younger ones. And so we kind of touched upon this. And I know for a lot of people that are listening, they're like, okay, so we get this number and what do we do? And there's lots of different numbers. So we're going to talk a little bit about a couple different groups of people. We've kind of briefly touched upon the concept of the power of zero. And for those who haven't been fortunate enough to hear either of you talk about it at one of our ASPC sessions or in your teaching time, do you remember when you really realized how transformative this could be in practice? And, how do you approach the calcium score of zero? And I know that's a big, heavy question as well, but we'll start with Dr. Blaha.
Well, I can remember exactly when we started talking about this, really, because there was a series of papers right as the journal JACC Imaging started. We published, I think, maybe 2 papers in that first one of those first issues on the concept of a calcium score of zero. I think this is 2008, Khurram, I
9.
think, 2009. Um, and I'll walk back. So we were talking a lot about calcium scoring at that time, and we were thinking, well, a lot of people were exclusively talking about high calcium scores signaling high risk and really not talking about the actionable nature of calcium score at both ends of the spectrum. So it was just about finding patients with high calcium scores. And that's great. And that was sort of the initial way people thought about this test. And maybe Arthur's initial goal was to find those people we didn't know were at increased risk. But as we moved along, especially as we're treating more and more patients are getting the calcium score, we started to think about this unique observation that these patients with calcium scores of zero do extremely well. In fact, they have a better prognosis than any group we can identify with risk factors alone. So we started to ponder a lot about thinking about that. Well, what's the application of this? This led to a systematic review and also a paper from one of our data sets on calcium scores of zero, looking at the favorable mortality trends over the coming 10 years. Remember, we spent a lot of time thinking about the discussion of that paper, Khurram, right? But we said, well, not only should this be driving potentially shared decision making with patients about preventive pharmacotherapy, should lead to less aggressive, testing in these patients. A lot of times patients were getting stress tests that we would see in practice at that time, who we knew had a calcium score of zero. I would see patients coming back recurrent visits to the emergency room who had a calcium score of zero. No one was using this information. Yet we knew that patients had likely to be almost no plaque in their arteries. So less testing, less expenditure. We were very worried about population health and kind of appropriate use of resources at that time, of course, and potentially shared decision making, which was another hot topic at the time. And this seemed to fit perfectly in with that paradigm. So I would say we started thinking about this the most in the mid 2000s, publishing our first key papers on this in 2009. I don't think we called it the power of zero yet. Um, Khurram coined that probably shortly thereafter as we try to communicate this key message that it's not just about high calcium scores. It's about low calcium scores too. And you're not unlocking the power of the test if you're only saying, well, I just want to see if your calcium score is really high. We also have to be have the courage, right, Khurram, to make it actionable when your calcium score is zero too. A true risk stratification test is not just one that finds high risk. It's one that finds both high risk and low risk. And if we're going to engage in this testing, we have to acknowledge we can find patients that are higher risk than we thought and patients that are at lower risk than we thought. And where this test becomes resource favorable is when we find some patients we treat more aggressively, but we also are bold enough to treat some patients less aggressively or order less follow-up tests on a group of patients who actually have a really favorable prognosis. But Khurram was my mentor at the time. He was a senior author on these papers, so he remembers even more detail than me about that time.
I would say, just adding a little flavor, the first decade of 2000 was really around the challenges at that time was that we had a scoring system that was very rigid in identifying who would need statins. And of course, if you go to any conference or most of the papers were around, look, these risk scores significantly underestimate risk, and we need better tools to identify people who should be treated. And hence, the goal of the calcium testing or any of other testing was who are the ones who are being missing. But of course, as we started looking at upside down and saying, actually, there's some more value here, I would say by the end of 2000, there wasn't much of an appetite around this concept to be applied. However, few things started happening. Number one, Jupiter trial happened, and that showed that even if your LDL is less than 130 and you have some inflammation, that statin utilization would significantly enhance. And I think so. That was the first application of the power of zero. And Mike published a paper a year later in Lancet and saying, well, if you would have taken people with Jupiter trial, actually half of them would have a calcium score of zero. And in 6 years of follow, which was double of their clinical trial, you're not even having any events. And you may need to treat more than 550 people to prevent one event, even if it makes an application. I think so. That was the first time that this concept got attention. Now, parallel things were also happening. Statin became generic. We knew that they're pretty safe. And then even if you treat a lot of people at low risk, it affected. And then the new guidelines in 2013, almost 12 years, came out and said, well, we're going to now have almost 50% of the adult population who's going to be on a statin. Now, the reality is people just don't want to take medications if they don't have to. And actually, the studies have shown that almost 40% of individuals will say, I don't want to take a medication, and they're willing to pay almost $1,000 out of pocket. If you can give me an information, I don't need medications. And even the cost worldwide is going to be high. So I always make fun that the statin island was getting crowded. I think so. That is where the true application started happening and saying, what if we take the guidelines or we slice and dice the risk factor any way you want? Hyperlipidemia, family history, age, US guidelines, European guidelines. Clearly, we showed that if you were going to use the guidelines and you would have taken a time and $100 upfront, almost about 40% of those individuals would have a calcium score of zero. And their 10-year risk is going to be much lower than what you would have anticipated that you would even consider. So the 2013 guidelines also promoted this concept of the shared decision making. And I'm saying, like, this threshold is not like where you start having a conversation. So I think that it was the need, the population, individual level health system need that got the concept of power of zero really excited by many people. And of course, it took a village to get it done. Ciccone Center, many other groups coming together to do this in concept. And it's really interesting to see that a concept that was just coming out in 2009. And in 2010, when I presented this concept at the Northwestern Young Investigator Award Series as a fellow, I was told to run away from it. This is like worst concept. And literally in 9 years, it got into the guidelines. So again, it wasn't just the data. Of course, the data is critically important, but if you don't have a need, then there's no point. So I think so the need started coming when we moved from undertreating to now opening the door for millions, I would say 10, 20, 30, 50 million individuals who may now need to take a few pills daily. That's where the real need came of the power of zero.
What an incredible privilege to be talking with two of the trailblazers who, did all of this initial research for the power of zero and really were courageous in their pursuit of explaining it to perhaps the naysayers, as Dr. Khurram Nasir had told us at ASPC. And so I think for all of our listeners, that's just such an incredible coverage and explanation about it. And thank you guys for doing that. I think the comment that you made about really focusing on the need first and then figuring out at a population level and expanding beyond that. I think a lot of what I've been learning and interviewing all the attendings through the podcast is just everything comes down to the patient, as we do in our day-to-day clinic practice, and figuring out what people need in their lives, and we meet them where they're at. Okay, so we've talked about zero, but what do we do if they're at like 1 or 2? Or what if their calcium score is somewhere in that 1 to 99 category? And a patient says, well, it's just 1, it can't be that bad, right? Do I really need to go on the meds? Where do you recommend that as trainees or even other cardiologists or APPs listening to this discussion, where should they start talking to their patients about that when their score is not quite 0? And we'll start with Dr. Nasir.
All right. So I think so. A lot of this work, I've learned a lot from Mike in this space, So, and again, historically, I've been more in favor of the absolute calcium scores. And there was this concept of percentile. So, for example, if you had a calcium score of 10 or 20. For a young patient, that's a very high percentile. For an elderly patient, that may be a low percentile. So my initial reservation around the percentile was that that may underestimate the risk of short-term risk in the elderly individuals, where you may have a calcium score of 80 and you say, well, you're below the 75th percentile, whereas we may be more prone in treating a younger individuals with a calcium score of 5, which may be a lifelong risk, but not the short. And then again, Mike and others clearly showed the huge value of in the early younger group on the percentile. So let me tell you how I do it in the clinic. If you have any atherosclerosis, the process has started, period. And now it all depends which time of the life cycle you are. If you are at a younger age, this process is likely going to mature more and much higher risk. So almost all of them need to get treated. Uh, Lifestyle management with some statin and trying to lower the LDL as much as possible. But I don't really push the intensification as much. This is more maintenance and prevention. However, once you cross a certain threshold, a calcium score of 100, and by the way, that's no magic number. By the time you get a calcium score of 100, Mike has shown that you have extensive atherosclerosis. At least 80% of individuals have three vessel disease, more diffuse, so much more high risk. That's where you have to throw the kitchen sink, I would say, and get their LDL below 70 or 55. Think about an aspirin, the more cardiometabolic therapies, and all of those. So, in essence, any atherosclerosis is bad, especially in younger groups. Now, the same calcium score of 1 to 10, we may have a little more uncertainty and flexibility if you are 67 or a 70-year-old male or a woman versus that. So, contextualization that minimal atherosclerosis in the later stage of your journey may not be as bad, whereas if you had the same minimal atherosclerosis as a young 45-year-old male or a 52-year-old female, that's where you have the true opportunity. So, Mike, what do
No,
you think?
completely agree. Yeah, it's all about the context. And the more you use this tool, the more you recognize this, of course. So the practicing clinicians out there know this the best, but calcium score always needs to be put in the context of, yeah, where you are in the life cycle, your age, your sex, your gender, but also your comorbidities, of course, too, competing risks. It's one of the reasons why at older age, you think about it a little bit differently than you think about it in a young patient. But yeah, absolutely. So I like the percentile concept in those young patients. And I actually make two percentile categories that are important to me. The 75th percentile is endorsed by the guidelines, is where we should be treating with a statin, for example. But I really like to see those patients above the 90th percentile too. I feel like that top 10 percentile is where over a third, about 40% of all events occur in the people at the top 10 percentile of a calcium score, which makes sense. They're at the most risk. They're the most malignant form or premature form of the disease. And those ones I really like to see in my prevention practice because I really treat those aggressively. So there's the 75th percentile, but then there's the 90th percentile, right? So if you're 40 years old, if you're a 40-year-old man, the 90th percentile will give you about a score of about 10 at age 40, about 100, between 100 and 150 at age 50, by 500 or so at age 60, and over 1,000 at age 70. Those are the same patient at the 90th percentile curve, just offset by decades. So once you see that patient in your practice and their score is 600 at age 60, you're like, well, I would really treat that patient aggressively. That's the same thing as a score of 10 at age 40, but offset by 2 decades. And that's the idea of prevention, right? We're trying to find patients, the same patients we would wish we would have treated earlier when we find them later and treat them earlier. So I look at that 90th percentile, I think about where that curve sits across the life cycle and say, well, this is that same patient, but offset by a certain period of time. So it makes sense to engage in prevention. So I like that 75th percentile. I like that 90th percentile. I like seeing those patients in a dedicated prevention clinic and being aggressive with them. I think a lot of us see those patients. So that's where that 1 to 10 comes in handy, right? If the 1 to 10 is in a 40-year-old patient, as I mentioned, they're going to be about the 90th percentile. Now, that 1 to 10 happens in a 70-year-old patient or an 80-year-old patient, it's a completely different story. And we're doing that big trial called the CAC preventable trial, where we're looking at statins in the elderly population and looking at the blinded calcium score. So we'll want to figure out a little bit more about what the actual values are in the older population. But clearly, as you get experience with this, you're thinking about the calcium score changes when you think about who you're treating: a young patient, middle-aged patient, older patient. So that 1 to 10 is all, as Khurram said, about the context. It's all about who you're seeing. Now, as far as imaging, we have a lot of imagers out there too. Now, of course, I recommend whenever you have a score of 1 to 10, actually to look at the image yourself and figure out how convinced you are. There's going to be some lower quality scans where you might want to repeat that in a couple of years and make sure that's a real finding. But if you've got a high quality scan, we've demonstrated, that was in our initial paper, Khurram, right? That if you've got a score of 1 to 10, you're at a twofold increased risk compared to a score of 0 um, over 10 years. And that's one of the reasons we made that distinction of 0 and non-zero. Even that low earliest manifestation of disease was distinctly different than a true 0. So maybe look at those images. If you're uncertain, maybe repeat it. I always look at the images, but if you got a high quality study, that's a distinct group from 0, and now figure out where you are in the lifespan.
Yeah, thank you so much. I think I love the focus on taking it into context and not looking at just one thing. And I really think the more I learn about prevention as a trainee and the more I have these conversations, we know that all of these are just tools that need to be incorporated to be individualized to a patient. And it takes time to really formulate their entire risk. And this is just one part of the puzzle, albeit a pretty important part. You talked a little bit about repeating this scan. I know we touched upon that here and there, but if a patient is coming back to clinic and asks us, what's the value in tracking their progression? And I know there's a different answer if they start at 0 versus not, but we can maybe dive into that a little bit. And we'll start with Dr. Blaha.
Yeah. So it's a great question. So the question that comes up from patients all the time, first, of course, is maybe they already have a high score and you're putting them on a statin. They say, well, can we check in and see how the statin's doing in a couple of years? Because it had some obvious appeal that we'd like to say, I would like to see our numbers get down. We'd like to see our LDL come down. We'd love to see our calcium score go down. So first of all, it's important for everyone to recognize, of course, like I to tell patients, is the calcium is the fossilized kind of remnants of of past atherosclerosis, right? So it's laid down. The calcium's not going anywhere. In fact, it's going to become denser over time and your score will go up. So this isn't a test where we can look at, track the efficacy of a statin over a couple of years and say, are we making atherosclerosis go away? It can't be used in that way. So that's the first thing to know. We shouldn't be repeating this test when it's already high. And we can't track the efficacy of therapy in that way. Now, you asked the question also about the score of like 1 to 10. Well, what about these kind of early pauses? Well, I do repeat the scan in those patients because that patient on a slow growth trajectory or is that patient on a rapid growth trajectory? And then, of course, there's the zeros because when we tell a patient they have a score of 0, we, of course, although some like to think we say that, we don't tell them that you're okay for life. We say, you're okay for now. Let's repeat that in, on our data would suggest mostly 3 to 5 years and check in again. And if you have a double 0, then you're on a better prognostic pathway than if you've progressed to a positive score. So there's really 3 distinct applications. When the score is very high, we don't repeat that. You can't track the efficacy of therapy. If it's a low positive, you can track the what trajectory they're on, help risk stratify them. And if they're 0, of course, you're going to ask the question, are they a durable 0 or is this someone who's started to manifest disease? That's where you're thinking about the age of the patient and such. So, and that, of course, unlocks, once again, the power of this test. It's more than just the one test. And when some people our naysayers sometimes say to us, well, are you really going to tell a patient that they're fine for life when they have a calcium score of 0? No, we won't tell them that. We tell them you're fine for now. We might check in again at the appropriate time, but you also do not need this every year, like a mammogram or every other year. Um, so the knowledge of that helps understand that we don't overuse the test, but we appropriately use it. But there is a value for repeat testing. We just need to use it in the right patients. But I don't think there'll probably ever be a value of taking that patient who's 1,000. You're going to put them on an aspirin, a statin, maybe PCSK9 inhibitor, and ever repeating that test. We should dissuade our patients from that because they will ask us that. I got asked that in clinic yesterday because, of course, it would make sense to a patient. But once you explain to them that this is the remnant of atherosclerosis past, we're not going to change that, but we can change the trajectory going forward, then they understand. Khurram, what do you think about that?
So I like how you categorize them. Definitely for me, a no repeat is as if you get close to 100 or more. And my response to the patients is when they ask, well, why are we not checking? And I give them the example, look, if you had a heart attack or you had a stent, we're not going to be going in and repeating imaging to see whether the efficacy of the therapies, we know what it is. And that's kind of, unless and until you start developing symptoms, that's a point where we understand that maybe the disease had progressed enough to cause functional impairment and we should think about it. But till then, very intensive treatment, lifestyle management, your regular exercises, your regular stress keeps an eye as you're asymptomatic. Now, of the 0, of course, Mike, you have clearly pointed out, and this is always like a thing that came out I think so because we called it the power of zero. People just thought that, okay, once you have a zero, this whole notion of zero does not mean zero events. I see that all the time in social media, in lectures, even in papers. And I'm saying, but which thing has a zero event? And when was the last time we said if your HbA1c was 5, you're never going to have an event or you shouldn't repeat it? So that same concept is, as what Mike has pointed, it's a snapshot. And we need to repeat it based on, and Mike has given us clear indications. Look, if you're really low risk, you can wait till 7 years. And if you're higher risk, like, for example, diabetes or lipoprotein A or early family history, maybe 3 years, and the rest in between. And yes, you still capture the disease at an early stage. And you're going to see a lot on the social media when they say calcium is end stage disease. I'm saying, what are we talking about? A calcium score of 1 to 10. In the short, long term, intermediate, the risk is not that high, and especially if you can manage them. So for Mike, for 1 to 10 score, and even slightly higher, I tend to do a little also what you recommended, see the images. For example, if somebody is a calcium score of 5, and after 18, 20 plus months, you repeat the scan, and the calcium score is now 35 or 40. Now, it all depends. If you had the same lesions, as you know, the calcium score is a multiple on the density times area. And if you had a low dense lesions and they became more dense, so your factor goes from 2 to 4, the area increases, and you have no newer lesions. I personally think, and then again, we need to do a little bit more research in this space, Mike, an area that you're really looking, versus you may have more lesions with the same score. So that can give you an idea whether the disease is more progressive or newer lesions. So it's not just the number. So I would caution our listeners that look at the images, especially if you're going to repeat it. Just don't look at the number changes, but look at the images and look at the number of lesions and the density to do that. But I think that it's pretty reasonable to repeat the calcium score in that lower range. I definitely persuade against doing in the high range. In the calcium score of 0, it all depends what's your baseline risk. But you have to repeat it. It's not once a lifetime test. You do it and forget it.
Amazing. And so one thing that we see in clinic a lot is people come in and they're like, how old do I need to be to get a calcium score? And how young is too young? And I know ever since my husband turned 30, he's been asking me every year, like, can I get a calcium score yet? So maybe this is questions for him specifically. But what do you recommend for patients that, now that we see there's more good information? I know we're combating misinformation, but there's good information out there about like patients kind of taking advocacy for their health and learning more about what's available to understand their coronary risk. How young is too young for a calcium score? And we'll start with Dr. Nasir.
Well, I rather have Mike give an answer on this because he's been thinking a lot. Look, it all depends. Most of our data and evidence was limited to age 45 and above and pushing to 40. So it was hard for us to really think about how more can we push. And this whole concerns that also happen in a young patient, you're going to find a lot of non-calcified plaque. And then again, what is the implication of those? So maybe we are reassuring a lot of individuals who may have the disease, et cetera, et cetera. Now, what we have seen is you can safely push the envelope to younger, definitely to 35 and even 30. And I would say the idea in that younger population is not more to reassure, but to pick up early signs of disease. So even if you have an FH of 35 and you have a calcium score of 0, the chances you're going to have an event in the next 5, 10 years not there. But the idea mostly is if you have early atherosclerotic disease, if you have few risk factors, pre-diabetes, obesity, some family history, you're going to definitely be a much higher risk at age 45 and 50. And this is the way to start. So I would say that the role of the calcium testing in the young is really not trying to reassure you, focus more on lifestyle. If your cholesterol's way out of the way, start some statins. There's no harm in that. But it's not to say, oh, you're low risk, so that's fine. It is more to say, oh, I found a person with a calcium score of 2. Now, this is the individual that is likely at the highest risk, maybe the 99th percentile for their age at that time. So I think so that is the thing where if it can help you modify your behavior and start intervention early, I would recommend in age 30 to 40 if you have few risk factors. That's kind of where the idea is. About 10 to 15% of individuals will have the disease. And Mike has shown that you need to really scan about 3 to 4 individuals to find one young 33-year-old male who may have early atherosclerotic disease if they had 3+ risk factors. Mike, thoughts?
Great points. A couple great things there that I'll amplify. It's so true. So you need to think about, of course, where you are in the life course. Early on, we're not trying to reassure people. We're trying to identify that highest risk of disease. In the middle age group, you can do both. You can both reassure or find high risk. And in older ages, we're generally finding patients who might have less risk than we thought, or they might have comorbidities we like to prefer to not treat if we can help it. And that's under clinical trial testing right now. But yeah, think about that specifically, that low risk population. I would point people to a couple publications. We had a nice publication in JACC a couple years back that really investigated this question specifically. It looks at how many risk factors you have and which risk factors, whether you're a man or a woman, and at what point in time there's a 1 in 4 chance you have calcium. In that paper, you can also look at other tables that look at 1 in 5 and 1 in 6. But at that point, we decided, well, a 25% chance of having calcium is a reasonable time when to do this test. You might not want to do the test when there's a 1 in 20%, 1 in 20 chance you have calcium, but 1 in 4, I think we'd all agree, is a pretty high yield test. And you can look up in that paper based on who you are. And the more risk factors you have, of course, the younger the age is. But in general, if you have no risk factors, a man at age 42 has a 1 in 4 chance of having calcium, and a woman about 12 years later has a 1 in 4 chance of having calcium without risk factors. And then if you add on risk factors like family history and dyslipidemia, a very common thing that we see, at age 35 for a man, there's a 25% chance you have calcium. I think it's 48 in a woman. So you can see it's, if you have risk factors in the mid 30s or mid 40s for a man and woman, makes sense. If you don't have any risk factors, it's probably a little bit later, as I mentioned. But that paper actually has guidance in there based on the profile of the patient, and actually says you can even calculate if you have hypertension, you get calcium X years earlier. If you have dyslipidemia, you get calcium X years earlier. So we can make this empiric. We can make this something that we can figure out. But when most people read that paper, they say, "Oh, wow, that's earlier than I thought." The reaction of most people is that, "Wow, there's more calcium earlier than I thought." We've even looked in 20 to 30-year-olds with risk factors. Now, while it's rare, relatively rare, there's about 8% of patients in the 20 to 30-year-old age range who had dyslipidemia who had some calcium. Now, the mean calcium in that paper was a calcium 4. You're picking patients up at the very earliest manifestation of the disease, but as you heard from Khurram, this is a very high percentile. But anyway, the answer to the question is, if you don't have any risk factors, certainly by age 40 in a man and 50 in a woman, you're going to consider it maybe a little earlier if you have risk factors or risk enhancing factors. But it also depends on what your expected yield is too. If you're content with the idea that I know there's only a 1 in 10 chance I'm going to pick up calcium, but I want to know if I'm in that 90th percentile, then you can do it a little bit earlier. But the message, of course, is not reassurance. It's, well, you're not in the top 10th percentile. But as I just mentioned earlier, I love that top percentile. That's where 40% of events happen. So that's the way we think about it. When we tell a patient you're a score of 0 at a young age, we might say, well, you're not in the top 10th percentile. Well, I can't even tell you if you're in the top 25th percentile yet. You're too young. But if we identify a disease, oh man, which we do frequently, those are the patients we can make a huge difference for. So we need to push the thinking earlier, but push the concept more towards early detection and not reassurance. But then as you move forward, of course, into middle age, that patient persists as a 0. Of course, then we can reassure them. So this is where the repeated testing and the age is into play. But the message for the audience out there, I think, is earlier than you might have thought. And you can go to www.cac-tools.com. That's the calculator for the percent chance of having a calcium by age, sex, and race in the 30 to 45-year-old age group. And if you want to just put numbers to it or report the percentile in your young patients, there's a tool for that at cac-tools.com.
So, Mike.
Amazing. Wow. Oh, go ahead, Dr. Nasir.
As you were talking, I think so. You just introduced a wonderful concept, and I'd love to do maybe a good slide on that. Younger individuals identification. Here, you are moving them in both directions. And as you get elderly, the idea is more around reassurance. So that's kind of the key thing is when people, are just going to go with the sound bites. And well, what about the young and the power of 0? 0 doesn't mean anything, or it's not like diamonds there forever. The concept is you use this tool.
Exactly.
Really where the real value is, and you have to put things into the context. So Mike, I love this idea.
Yeah, exactly. And the reason why, of course, we talk about this is, of course, when we give a lecture, we can laugh because we get the same questions every time. But hopefully people are getting more mature as they understand the test. But early on, we'd always get the question, someone would raise their hand and say, what do you do when the calcium score is 50? Without any context. Well, I don't, or what do you do when the calcium score? Well, you have to know who we're talking about here, where they want some kind of concrete answers. Well, I do X when the score is Y and Z when the score. You can't. You have to always keep in context. And I think we've started to get that message out more, Khurram. But the patients want to have a very simple kind of rule, but this is the beauty of it. A true prevention, a true risk stratification test, you have to appreciate where you are in the life course.
Exactly.
Exactly. So what Khurram said, and I want to make one more comment about that, which is, I'm not sure we'll come back to it, but I'll mention it now, is of course, detection of calcium on non-gated chest CTs. The incidental detection of calcium. The same thing applies, right? So if you're a radiologist, right, and you detect calcium in the arteries in a young patient, that's absolutely reportable, right? We need to know that. If you're in the middle age, it's important whether you have calcium or you don't. And if you're at an older age, it's probably not important to note that there's mild calcium, but it's important to note when there's zero. So if we can get that simple message out. It also applies to when incidental calcification on a non-gated chest CT is important. But any calcium in a young patient should be reported. You can imagine we can make a big difference there. Um, I think you're correct, right. There's a lot of important messages in there, even for the radiologist that might be listening, or people who read calcium scores.
Yeah, what an incredible conversation about, taking it into context of a young patient. I love the point that you made and Dr. Nasir touched upon, and definitely tucking this into the back of my head for when I talk to patients about younger patients that are asking for calcium scores. It's not a reassurance score. We're trying to detect. That was just a really powerful statement that I definitely am gonna take home not only to my husband, but also to all of my patients in clinic. Um, I want to wrap up with a quick little rapid fire round. I'm just going to ask you some questions, and you can feel free to to throw out an answer. But I'm going to start with calcium scoring in primary care. Do we overuse it or underuse it? Do you think right now, currently?
Definitely underuse it.
Yeah, without question, underused. And I think the biggest thing we have there is heterogeneity of use, right? We have some primary care doctors who are using it a lot, and you've got swaths of the whole country that are not using it whatsoever. And of course, as guidelines evolve, hopefully that becomes more consistent, but vastly underused by many physicians, and maybe they don't use it at all.
What is one patient, and these are very generalized, as we've discussed, there's nothing simple about, understanding risk in the setting of a calcium score. Everything's in context and everything has to be individualized. But what's one patient type that you would say should definitely get a calcium score?
Mike?
Yeah. Oh, geez. I mean, I think the answer is almost everyone. When you hit them at the right point of their life, right? Um, we're all frustrated when we get the referral of the 70-year-old patient with a calcium score of 1,000, right? The only thing you can think about is, God, I just wish I knew about this 20 years earlier. Of course.
Totally.
So really, I mean, it's patients who are concerned about their risk, who have questions about their risk, who are in the borderline to mid-range of the risk spectrum, which means young to middle-aged patients, patients who have a risk factor, and really, it's most patients, but of course, it's at the right time of their lives, which is what we're getting at, right? This doesn't mean everyone needs it when they're young, or everyone needs it when they're old. At the right time of their lives, but everyone by middle age who thinks about heart disease, who is at risk for heart disease, should have had a calcium
So
score.
I would say is anyone male early 40s, female early 50s, if you have multiple risk factors, age 30 to 40, and once in a lifetime, at least, even if you're elderly 60 and above, to know the degree of burden that can manage there. It's not around initiation most of the time, it's the intensification.
Yes.
So I think if we can do that consistently across the board, you catch up the early disease, the calcium scores of fives and tens, and intensify the management and shift the whole curve to the left. I think that's what it is. So for me, uh, it's a simple algorithm. Most.
Maybe we hit on this one already, but the most misunderstood calcium score number, although I feel like we've kind of hit the head on the nail with this one.
Well, I'm going to change
Zero.
the question a little bit. How about some misunderstood things about the calcium
So
score in general?
Totally.
Score. I'll just give a couple rapid fire ones myself because the same ones come up all the time from patients. I'll just do them rapid fire. Number one, is it because I have too much calcium in my diet? Of course, we need to make sure that patients understand this is different than your serum calcium level or calcium in the dairy products. So I just bring this up to my patients right in the middle. 2, if I have a calcium score, am I allowed to exercise? Well, of course you're allowed to exercise if you're asymptomatic. We want you to exercise. Physical fitness is one of the most strong predictors of favorable outcomes if you do have an event. These comes up all the time. We talk about the repeat calcium score. That always comes up from patients. Yeah, most understood score. I'd say the most misunderstood score would be the low positive score. So, quick anecdote of a patient I had recently. Saw a patient. He's a prominent lawyer in this metro area. Comes in, wants to know his risk. I'm talking about risk, and I said, "Well, you should probably get something called a calcium score." And he said, "Oh, I've had that before. I've had a calcium score before." I'm like, "Oh, what did it show?" He said, "It was fine. They said it was fine." I'm like, "Oh, was it a 0?" He said, "No, it wasn't 0, but it was low. They said it was fine." I'm like, "Well, do you remember what the score was?" And he said, "No, I don't remember." Of course, I had him pull the score, right? He was in his young 40s and his score was 20. And at that time, he was told, "It's low. It's not above 100. You're fine. Don't worry about it." Of course, I repeated that. It was above 100 by his late 40s. So that was a misunderstood score. It was misunderstood that his score represented the 90th percentile at that time for this African American gentleman. So I would say low positive scores are misunderstood the most for me.
So,
Khurram.
yeah, same thing. I would say in this day and age, apart from the most misunderstood score in the academic and social media is the power of zero. And we always had fun around that. But I would say a new emerging thing that's coming, which is, I would say a little concerning, but again, something that we need to do. But what about the non-calcified plaque? So that we can do another whole podcast on that. So there is a lot of temptation through actual influencers and podcasts around tempting to chase the non-calcified in the calcium score of 0. Now, of course, we have done the study in the Miami Heart Study. Yeah, about 10% of individuals, 15 have exclusive non-calcified plaque, literally a streak in one segment. Clearly, if you look at confirmed registries, Scott Hart, and now even the SCAPIS Heart Study, there is no meaningful prognostic power beyond the calcium score of 0. Just to give you an idea, that if you have a calcium score of 0 in SCAPIS study, which was a Swedish study of 20-some thousand individuals followed for 8 years, your 8-year event rate was 0.5. That, if you can divide it, it's about 0.06 in 1 year. Less than 1%, 10 years. And if you had a normal CT angiogram, your event rate is 0.45%, 8 years. So it's not adding much. So what I tell people that let's not make the exclusive non-calcified plaque the new boogeyman. Let's not mistake detail for depth. And not all plaque is destiny. And the outcomes tells that the calcium score of 0 is safe. So in this word, let's not trade simplicity for spectacle. That's kind of like a lot of the things that we're seeing. But what about the CTA? And now, even with the AI plaque detection, we push the envelope even further and detecting almost much more plaque. And rightly so, the JAK editors and even the European imaging societies are now cautioning and again saying, we should really be, is this an actual disease? Is this something we should be worried about? Of course, we need to think a little bit more, but I'm seeing, Mike, a lot of this conversation is around what about my non-calcified blood?
Oh, completely agree with this. Not in the paradigm study, the people with calcium score of 0 who had non-calcified plaque was 30 millimeters cubed, the smallest little amount of plaque. As you said, with the AA protocols, it's not very reproducible. You do a scan and send to one A platform versus another. One finds plaque, one doesn't find plaque. These minimal amounts of non-calcified plaque are probably not actionable and probably not enough reproducible right now. They don't add to risk prediction. So I completely agree. We don't want to muddy this message. If you have a calcium score 0, you have a favorable prognosis. You can repeat that study. So I agree on the non-calcified plaque part completely. I want to talk about one more group real quick. High calcium score, should I get a stress test or should I get a cath?
Yeah.
Of course, right? We need to talk about that real quick because this is something that's gotten the field in a bad place in the past. And as preventive cardiologists, we've always been pretty clear on this message, right? If you don't have symptoms and you have a high calcium score, it's all about medical therapy. It's all about medical therapy. And of course, Courage and the ischemia trial have all supported our stance that we've had for decades on this, but gave us some clinical trial evidence to support that it's a medical disease, right? That we need to treat medically. So when patients, you have to have the courage, again, If a patient comes in with a high calcium score, but no symptoms whatsoever, now, of course, you double down and ask them about their symptoms and really drive down, but they have no symptoms. You have to have the courage, once again, to avoid downstream testing when it's not appropriate. So that's another one that's misunderstood. We still see the high calcium score who gets sent for the stress test, who gets sent for the cath, and it shouldn't happen, right? Those patients should be aggressively medically treated and selectively, as a general cardiologist would, order tests when patients have symptoms. So that's another misunderstood one that I think the preventive cardiology world understands very well. But the message to the general cardiologist or the primary care needs to get out there too, to not reflexively say, well, the calcium score is high, let's get a stress test. How many of us even believe in stress testing that much anyway anymore? So let's get away from that and more towards aggressive medical therapy and stress testing or cardiac catheterization, of course, when appropriate. The National Lipid Association gave a class 3 recommendation to do reflexive downstream testing in high calcium scores. Don't do it. This is an important part of the message too. That gets confused sometimes. Sometimes people think that we do calcium scores to drive revenue streams or something like that. It's actually the opposite. We do calcium scores to be more conservative with our medical therapy, more medical and preventive in general. So that's another one to quick discuss.
I feel like we've just barely scraped the surface of calcium scores in this episode, but it has been just such a pleasure chatting with you both. One thing that you mentioned that I just love that I pocketed also is kind of we talked about calcium scores as fossilized remains, and I just loved that. And I think patients really resonate well with a quick and easy way for them to understand kind of why we do the tests we do and whatnot. And we talked about the fact that calcium scores don't discriminate. They're applicable to a multitude of people, taken into the context of what point in life you're in, which is really, really important. We look at it where the risk is uncertain, not just to initiate, but to intensify, not just maybe to reassure, but also to catch those high risk patients, and lots more to come in this space. And just an absolute privilege to chat with both of you today. And I'm sure there'll be more things to discuss in the near future regarding calcium scores, but I know I've taken away lots of things to implement in my clinic, and I'm sure other people feel the same way listening. Thank you both so much for taking the time.
Thank you so much for having us. It was
Thank you so much. And
fun.
I'll say a special thank you to Khurram, my longtime mentor, really one of the giants in this field. We've had a great partnership over a long time. Khurram, great to do this podcast with you. I don't know, 20 years since in this very
Yes.
room we started talking about calcium scores of 0.
I love that.
More to do, Mike, much more. Thank you.
Thanks, guys.
Thank you so much for listening. To learn more about the ASPC, please visit our website at aspconline.org.